TopMedTalk. Well, hello and welcome to TopMedTalk Down Under. I'm Andy Cumpstey and I'm here with my co-host Kate Leslie at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting in Brisbane, Australia. And as we've been saying all weekend, it's one of the largest meetings in this part of the world. And despite a pretty impressive gala dinner last night, there's lots of people here this morning filling in. And there's a really good buzz around the hall again, isn't there, Kate?
I think there is. There's nothing like a great gala dinner to encourage collegiality and networking and just for people to have fun. There's, not enough fun in life often when we're working and doing our research and leading departments. And so a bit of playfulness is always good.
Well, there was a lot of that last night, and I can definitely say that being here in Australia, you Australian and New Zealanders definitely know how to party and have some fun. So it was a really good evening.
We'll take that as a strong endorsement.
And if you're at home thinking you should be part of it, then come next year and join in the festivities next year. It's apparently an annual event.
Yes.
And a big part of this meeting, I believe, as well.
It's people like it.
Yeah. So this morning we've had some really, really thought-provoking, brilliant sessions from some excellent speakers who are going to ask to introduce themselves now.
Hi, I'm Deborah Culley. I'm the chair of Anesthesiology and Critical Care at the University of Pennsylvania in the United States.
Brilliant. And
I'm Jamie Sleigh. I'm Professor of Anesthesia at the Waikato Clinical School of the University of Auckland in New Zealand.
Thank you both for a really excellent session this morning. So, you both gave very interesting presentations that I think eloquently encourage us all to think differently about both our practice and our research, and in quite an enlightening way as well. I think there's probably too many kind of little take-home points to cover even in this session, but this is a summary for people that weren't able to make it. I've never seen anyone twin King Charles and Ozzy Osbourne before, so that was a good moment. But also things about, are we asking the right research questions, and are we asking about the individual treatment effects or the average treatment effects? And maybe we don't actually need to get rid of the p-value of 0.05 because we all know it's a dumb thing anyway. What I really want to start off with, and maybe we'll start with you, Deb, is this concept that you presented about having an anesthesia or having an anaesthetic for major surgery is not just a cardiac stress test, but also a brain stress test.
Yeah, I think it's a little bit different than a cardiac stress test because usually you don't have an anesthetic that needs to be involved there, but very similar to it. There is some perturbation, that being the anesthetic, on a brain that might be a little bit abnormal, and you only notice that it's abnormal because you've given the anesthetic, and now all of a sudden somebody who should have a normal EEG but be asleep is in burst suppression, and that's abnormal.
And you gave some very nice data supporting the potential risks of this as well.
Yeah, there are a number of things that we talk about, in particular advanced age, no surprise. Things like frailty, cognitive impairment are always predictors of adverse cognitive outcomes in the postoperative period, but I'm certain that there are other things that we really haven't studied yet.
Jamie, do you have any thoughts about this? And this is an area that you're also very interested in.
Yeah, I think the idea of stress test is a very good one. I mean, there are some studies in intensive care patients where they give them bits of propofol, and if their brain's okay, you should get a normal sort of sleep-like EEG pattern. But if you fail to do that, this can be used as an adverse prognostic indicator. But for various reasons, there's some covert brain pathology of some sort going on.
Do we have any idea about what that pathology might be? Or,
well, I think it's still early stages for the ICU stuff. I think even for anesthesia, I mean, essentially what you're looking for is a normal pattern in your EEG. It's like slow wave sleep with decent alpha and delta patterns, similar to you'd see in a young person. And that's driven by thalamocortical oscillations. So as we get older, we get less and less of those. And you get all sorts of divergent, unpredictable brain responses to the anesthesia, which are, for various reasons, pretty important in terms of predicting when you're going to wake up with some cognitive problems. And possibly also the actual way that you wake up. Your mood it may be important that what you want to do is go through the stages, slow sleep, REM-like sleep, and then awake. That's a good trajectory. But if you just suddenly transition from very deep anesthesia to wide awake, often there's problems afterwards, which are probably analogous to sleep pathologies. night terrors and that sort of stuff.
There are so many things in what you just said that I would love to follow up on. But firstly, just for the benefit of our listeners, could you give us the basics of what you were talking about in the EEG, the frequency bands and the slow waves and sleep spindles?
Yeah, so when you're awake, roughly your EEG contains all the frequencies up to 30 or 40 hertz in a more or less equal amount of power. And then when you become anesthetized, you lose the high frequencies, and the frequencies of your brain really fall into two main oscillations. The delta frequency is around about 1 bit over 1 hertz, and the alpha frequency is usually about 10 hertz. And so that's the same pattern or similar pattern to you see in slow wave natural sleep, where you get what are called sleep spindles, which are like the alpha powered around 10 to 12 hertz. And the delta waves, which are the slow oscillations around 1 hertz.
And why do the elderly lose that alpha band in their EEG spectrogram?
I don't know, we can say for sure, but generally that band is an indicator of good connectivity between your thalamus and your cortex. So your thalamus and cortex sets up this kind of oscillation at that sort of frequency.
And is that band, is it lost with age, or is it lost with frailty and comorbidities and disease?
Well, I think you have to distinguish brain age from chronological age. And so you will find old people with young brains and vice versa.
There's 3 of them sitting in this podcast right now.
So sure about that. In some ways, that's one reason why looking at the EEG is so useful, because you do get more specificity than just saying, oh, well, anyone over the age of 70 is in trouble.
So Jamie and his colleagues have written several terrific papers about how to teach anesthesiologists to interpret the EEG using commercial products that have a processed element to them with a number, but also that display the raw EEG. And we'll commend the listeners to find those because they're incredibly helpful. Are you familiar with Jamie's work about teaching anesthesiologists electroencephalography interpretation?
I think everybody is. It's a matter of really being able to understand it. It is so intense when you're trying to really learn what it is that's going on. I mean, even the lack of connectivity component and whether or not that's a part of normal aging versus whether or not that's a part of abnormal aging, I think is something that I'm not certain of yet. And I'd be interested in your perspective on that, Jamie.
Yeah, it's difficult to know what to call physiology and what to call pathology when you're talking about age.
So, Deb, there are other markers of potential vulnerability to delirium and cognitive decline that you've been investigating in the form of biomarkers. Can you tell us about your research?
Oh my goodness, yeah. It's incredibly fun, incredibly complex, and it requires statistics that I don't completely understand. I have to hire a biostatistician to do most of them. But there are some pathways that seem to be involved with things like cognitive impairment and delirium, and we're not the only person that's looking at them. I think the challenge is we need to get to a point to where we identify those common pathways and those things that are really common from one study to the next. So we did a very large one looking at protein expression and whether or not there were changes associated with delirium versus not delirium. And I found it very difficult to find other people that had used that exact same platform to look at those outcomes to determine whether or not they were valid. Ultimately, we all need to be getting the same pathways. We need to be identifying the same processes by which it occurs. I don't think that we're there yet.
So I had previously imagined that the molecules you were assaying had leaked from damaged cells, but now I realize you're talking about changes in genetics and epigenetics in cells that have been affected by aging and that they're making different products.
Not necessarily. No,
Okay.
I think that there could be a little bit of one or the other and potentially both, but I don't know that I would say that we know the answer.
Because things like neurofilament light, that is definitely something that is leaked from an apoptotic cell or some other damaged cell. Is that correct?
That would be true, but there are so many other things that are not even related to things that you would normally think about occurring in the brain that seem to be associated with the development of delirium, which is really interesting.
So how do we deal with that in a patient coming for a high-risk operation then? Can we screen for these things preoperatively? or can we intervene to prevent them developing postoperatively? Or is that still a little way in the future?
I think in many ways that's a little ways in the future because we need to find those commonalities. I don't think that there's one screen, even neurofilament light, which looks really good. It depends upon the study that you look at as to whether or not it's actually cognitive. And, some of the other things like the release of GFAP, things along those lines. One study will say it's a biomarker and another will say that it's not. So if the real question you're asking is whether or not we have a specific biomarker for the likelihood of somebody developing postoperative cognitive dysfunction or delirium, I don't think that we have the answer. There are some phenotypes that make us recognize, and those would be the things that you've talked about. Patients with baseline cognitive impairment would be a very heavy hitter. The challenge there is that elderly individuals are able to appear okay when you meet them in the preoperative clinic. And so you don't really know unless they come with a diagnosis of Alzheimer's disease that they have cognitive impairment. So I think those screening tools are incredibly valuable. Remember, they're not diagnostic. They're just screening tools for probable cognitive impairments. You don't want to tell your patient that they have it. But also things like screening for frailty, because frailty is a very strong predictor of whether or not you're going to have cognitive impairment in the postoperative period.
And how much of this can we screen for? So we're starting to talk there about delirium, cognitive impairment, postoperative cognitive dysfunction, which some people might be using these terms interchangeably, but they're not the same thing, are they, Deb?
No, they're not. Baseline cognitive performance is, are you normal? Are you slightly abnormal? Are you demented? When we're talking about the postoperative period, there's a huge difference between delirium and postoperative cognitive dysfunction. And delirium is basically an acute confusional state, oftentimes associated with cognitive deficits, whereas postoperative cognitive dysfunction is really associated with a change in testing scores from baseline to the postoperative period. So they're very different.
And are there any sort of time periods linked to those definitions as well, or is it relative and flexible depending on the system we're using?
Yeah, it depends, because it'll depend upon the type of surgery, the patient that's there. So you could imagine a patient, in particular a younger patient who's had a large surgical procedure, has been in an abnormal environment, has elevated circulating inflammatory cytokines, who might be delirious. I can give you an example. One of my sons had a viral infection that he'd gotten overseas, and boy, when he was talking to me about it, he didn't talk to me normally. His wife calls me and says, he is screaming and telling me I'm trying to kill him. So I said, I think I called the hospital, and he ended up having a huge inflammatory response as a result of the virus. That's a really young person, so it probably takes something extreme. Whereas for somebody who's a little bit older, you probably don't need much. It's probably has something to do with the damaged brain as well as some of the things that we're doing to them in the perioperative space.
Jamie, there's a big controversy about whether the depth of anesthesia has an influence on postoperative delirium and cognitive decline. Reflecting on the balanced anesthesia study, which we worked on together, we showed that there was no difference between deep and light anesthesia with respect to 1-year mortality, but a difference in the rate of delirium. The problem with the balanced trial was that we titrated the anaesthetic to a BIS level of 40 or 60, or in that sort of range. And we've discussed whether that was the right approach. What would your suggestion be in that area? Because we could be titrating it to some other EEG measure that's more meaningful than a BIS number, for example.
Yeah, so the whole problem is that BIS wasn't really developed on old people, which is the people we're interested in. You have a lot of variability, so it's a very imperfect measure of the brain's response to anesthetic concentrations. But you're sort of obviously in a bit of a bind, because if we come up with some complicated measure, it'll be very hard to institute in a large trial. Personally, I would titrate the anesthetic to the delta power of what we think that particular patient could do. So you could imagine if you got a little sigmoid dose or concentration response curve, and as you turn up the normal hypnotic, I'm not talking about nitrous oxide, you'll get more delta power, and then there'll be a plateau, and probably it'd be reasonable to try and find the plateau for that individual patient, because if you go a bit too far beyond that, you're going to go into burst suppression generally.
And that would identify people who have an unusual sensitivity to anesthesia.
Yeah, so it's an individualized sort of approach to titrating anesthesia, but it's kind of trickier. So to be able to institute that in a large number of operating theatres, I don't know how practical that is.
So we really actually haven't got many clues about what to do during anaesthesia to prevent postoperative delirium or cognitive decline. The team at St Vincent's Hospital in Melbourne have looked at a number of things, general versus regional, operations versus cardiology procedures, etc. And people overseas have done lots of different things. We've found a sort of suggestion that the depth of anaesthesia might be important, but that needs to be confirmed in large studies. Deb, are there any other things that the clinicians who are listening should be doing to try and prevent delirium in their patients?
Well, I'd like to go back to the EEG component because I think that there's something really there. Those patients who go into burst suppression at anesthetic concentrations that are where you wouldn't expect that to happen, I think is an area that needs to be studied and to identify what it is that's actually going on in those patients, because it's very interesting, the concept that two people of the exact same age with what we think is normal everything else, they can have very different cognitive responses to the drugs. And it's interesting as an anesthesiologist, sometimes you can predict those people and sometimes you just can't. And I find it very interesting when you see the BIS on induction just drop straight to zero with a relatively small dose. I actually tell their family members that I saw it and that you might be looking for some delirium or cognitive deficits in the postoperative period. Not that it'll happen, but that their response to the anesthetic was abnormal.
And if you see that in your elderly patients, should you titrate the anesthetic upwards until it disappears?
Oh, that's a really good question.
I could try you to answer it as well.
Yeah, I've tried that before. What is very, very, very bizarre is it's really hard. Like if you're doing a propofol anesthetic and you get an older person and you've now got them on 40 mics per kilo per minute of propofol, which is way below what should be putting them to sleep, and they're still in burst suppression. I don't know that I trust the EEG enough to go any lower, and I don't want them to have awareness. So you're sitting in that funny space.
What do you think, Jamie?
Well, if the EEG is in burst suppression, I think you can trust that there's no awareness. But the problem is you've got to bring into the surgical stimulus into the equation as well. And if you have a very low amount of propofol going, it's pretty easy to wake up quite completely and quickly if the surgical stimulus trains. So like the classic is obviously in the craniotomy, there's no surgical stimulus once they're messing around with the brain. And so often those patients will drift into burst suppression because there's no, but you really don't want your craniotomy patient waking up at a delicate part of the procedure.
And what sorts of delays are people getting in these measures when they're seeing their patient go into burst suppression on the EEG?
Well, you can see it almost instantly on the spectrogram.
And from the stimulus, you see the response instantly as well, or is there a lag time with that?
Well, it's pretty quick.
Yeah.
So there's a whole lot of other dimensions to anesthesia that you shouldn't completely ignore. Conversely, with burst suppression, it is an indication of disturbed mitochondria. And my first response actually would be push the blood pressure up 20 points, and you sometimes find it goes away. And then this is telling me anesthesia plus incipient brain ischemia. This person, you might want to change your MAP targets, and there's a whole lot of other stuff you've got to kind of think about.
It's a good point you make about considering other things. The anesthesiologist not only knows what drugs are being given and a whole lot of stuff about the patient, but they're looking at the surgeon and they can hear the sound of blood going into the sucker. They know their surgeon so well that they can anticipate what that surgeon's going to do and how he or she is going to respond to a crisis, or all sorts of subtle things that it's going to be interesting to see if AI, for example, we don't really want to talk about AI, whether that's going to make a difference. But there are other things too, Deb. What about benzodiazepines?
Oh, well, benzodiazepines are really interesting. They're a part of the Beers criteria from the American Geriatric Society, which is basically a list of people not to give the elderly. But as you probably are very well aware, a large percentage of elderly individuals are at baseline on benzodiazepines. So if they're on benzodiazepines, I'd continue to give them because I don't want them to go. through withdrawal. If they're not on them and I can kind of support them and sedate them with other means, you've got a whole bunch of other things that are armamentarium, things like dexmedetomidine that don't seem to have the same effects. I would prefer to use those.
I think we're starting to slightly run out of time, unfortunately, but just as a closing question to both of you. So I know Deb and I have both come in the first time to this meeting. I know, Jamie, you've been to this meeting a number of times before over the years. But for this particular meeting here in Brisbane, Limitless, what's been your highlights of the event so far?
Well, it has been a spectacular meeting. Lots of things to learn, but I have to tell you, my favorite thing so far was to go to see some koalas at the koala sanctuary. I'm not sure that anyone would be able to beat that.
It's a pretty special day, that, wasn't it?
It was a very special day.
And Jamie?
I like the Gilded Brown session. We're looking to the future. There's some pretty bright people out there.
What sort of topics came up in that this year then? So we were unfortunately podcasting when that was being...
There was a whole selection. There's one chap I worked with who's looking at xenon EEG, and there was various ways of handling excess theatre waste. There's a whole selection.
Yeah, a really wide variety. Yeah. And we're looking forward to seeing that prize awarded later today in the closing ceremony to see who walks away with the accolade. Fantastic. Well, thank you both for joining us here on TopMedTalk. As always, you can find this and every other podcast we've done on our website, on our app. You'll also find all the other podcasts from this conference and the conference newsletter. And make sure you follow us on Twitter, or now X, Facebook, LinkedIn, and on our YouTube channel. Thank you very much for joining our conversations.
Thank you.
Thank you.
Thank you so much.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.